Okay, so for this PowerPoint, we're going to be talking about VQ mismatch, identified as Shunt and Deadspace. This is one of those topics or concepts that has a very wide range of applications. We're going to spend a lot of time on it. So I'm going to do this PowerPoint recording and lecture, and then we're going to talk about it in class. And hopefully I'll come up with some more videos or more explanations for this topic so that you guys can really wrap your brains around it. But just know that this is a large concept, so think about questions that you have for when we meet for lecture, any new or different ways that I can explain it. I really want you guys to let me know where you're at and give me an indication if this is not landing after you've gone through this lecture. So, dead space. Dead space is ventilation without perfusion. Okay, ventilation, you can think about the lung. Perfusion, we're talking about blood flow. We're talking about your capillaries. So, dead space is where you have ventilation without perfusion. So, you can imagine it as areas of the lung, alveoli, that exist that don't have any blood flow going to them. So, you have oxygen there and you don't have any blood flow. Okay, there's two types that we're going to talk about. There's anatomic dead space and alveolar dead space, and I'll further define those as we go through. But just really, dead space is ventilation without perfusion. So anatomic dead space, this is going to occur naturally. So all of your conducting zone, and we talked about your conducting zone being your nose, your mouth, your trachea, your mainstem bronchi, all the way down through your terminal bronchioles, right? Your conducting zone. This is all naturally occurring dead space. This is an area of the lungs where there's a lot of ventilation, but not much perfusion. There is some blood flow, but not much. This is kind of the area where your gas is being heated and humidified, where that debris is being removed. There's not very much gas exchange happening here because there's very, very little perfusion. So this is normal occurring natural anatomic dead space. This has nothing to do with your overall health. This is something that is going to occur in all individuals, anatomic dead space. Your alveolar dead space is different. This is going to be more of your disease-oriented dead space. So this is alveoli that have ventilation but no perfusion. Okay, and this is the same definition of dead space, but what makes this a little bit different is your alveoli should have lots of perfusion. We're going to talk about how the pulmonary circulation or the blood flow in your lungs is gravity dependent, but essentially just know that normally speaking, your alveoli have lots of perfusion. So if for some reason your alveoli don't have perfusion or they have compromised perfusion, this is going to create more alveolar dead space. So your lung is functioning well, but for some reason your blood flow has been compromised. There's several things that can cause this, but a couple examples so you can kind of think about it conceptually is if you had a pulmonary embolus, which is just almost like a blood clot that blocks blood flow. Circulatory disorders, which there's a lot of different things that can happen to compromise blood flow in someone's body or to give them a disease state that will affect their circulation. Blood pressure issues, all of these things could compromise the blood flow to your alveoli and make it so that you have an increase in dead space, which is not something that you want. When you think about ventilation, which is the bringing in of oxygen and the getting rid of CO2, you want your lung to match up with your blood flow because that's how these gases are going to be diffusing. You have oxygen that's diffusing out of your lungs into your bloodstream, and you have CO2 that's diffusing out of your bloodstream into your lungs. And you want this to go very smoothly. You don't want anything to interrupt this process or compromise this process. So alveolar dead space would be if you had some sort of compromise to the perfusion in your alveoli so that you would have ventilation without perfusion. So this kind of shows you what I'm talking about here. So here you have an alveoli and you have all these capillary beds around it, right? So you have good diffusion happening, that CO2 is coming out of your bloodstream into your alveoli so that you can exhale it out, and that oxygen is going out of your alveoli into your bloodstream so that it can feed your tissues the oxygen that it needs. The anatomic dead space is your conducting zone. So this is an area where you have naturally occurring low perfusion, and it's because your conducting zone is where we are going to be filtering, heating, humidifying that air. There is some perfusion. It's not that absolutely no gas exchange occurs in the conducting zone, but it's very, very little. Alveolar dead space is not a naturally occurring thing. This would have to be caused by some sort of disease process because your alveoli should have lots and lots and lots of perfusion. So if your alveoli do not have perfusion, that would not happen naturally or normally. That would be because of some sort of disease process. So if you have ventilation without perfusion, see how it's showing you how in this diagram how there's no perfusion. So the lung is functioning normal, but something's going on with the blood flow here where it's not getting to the lung and it's creating more dead space than what should happen. The second thing that we're going to be talking about is shunt, and the shunt is the opposite of dead space. A shunt is perfusion, so you have plenty of blood flow without ventilation. So again, kind of coming back here, your ventilation is your lung, your perfusion is your blood flow, your capillaries. So for your shunt, you will have perfusion, you'll have blood flow, but you will not have ventilation. There's two types of shunts, just like there was two types of dead space. You have your anatomic shunt, which is normal or naturally occurring, and then you have your alveolar shunt, which would only occur because of a disease process. So we'll talk through those. So your anatomic shunts, this is what occurs in everyone naturally. Whether you're healthy or not healthy, this is going to happen in everybody. You have two things that create an anatomic shunt. The first one is there's a portion of your cardiac output that returns to the left side of your heart without being oxygenated. This one I feel like is a little bit hard to envision without us going through more of the anatomy, which we do later. But ultimately, when you think about the blood that comes from your body that is returning to the heart, it returns to the heart on the right, okay? So you have blood that's coming back from your body to your heart on the right side. The right side of your heart then sends that blood into your lungs. And this is where the gas exchange is going to occur. This is where that blood is going to pick up oxygen and drop off CO2 is in the lungs. Then that blood leaves your lungs and it goes to the left side of your heart and goes out to your body. So there's this shunt that happens because you have bronchial venous drainage and Thebesian venous drainage. And all this means is that there's a certain portion of blood that goes from the right to the left side of your heart and it bypasses your lungs. This happens in everybody. It's a naturally occurring shunt. So blood goes from the right side of your heart, does not go to the lungs like it should, goes directly to the left side of your heart and out to your body. So because these two drainage sites don't go to the lungs, they don't pick up any oxygen. So these are poorly oxygenated venous drainage that's then going to go out to your body. So this is a naturally occurring, you have perfusion, but you don't have ventilation because this is bypassing your lung. The second thing that causes normal, naturally occurring shunts that happen in everybody is that you have something called regional differences in your lungs. So your pulmonary circulation is very, very low pressure. So if you think back to A&P, you have your systemic circulation, which is the blood circulation in your fingers, your arms, your legs, your feet. That is more high pressure, and it's more high pressure because when you think about having to send blood throughout your whole body, it has to be higher pressure to get all the way to the tips of your fingers. If you have your hand raised up in the air, that blood still has to get all the way to the tips of your fingers, right? So it's a higher pressure system. Your pulmonary circulation is just referring to the blood that flows through your lungs. That's it. That's much lower pressure because it's only getting from the right side of your heart into your lung and then to the left side of your heart. So it doesn't need to be very high pressure. The other reason that we want that to be a low pressure system is because, again, we've talked about the respiratory zone of your lungs being this very fragile tissue. You have those type 1 pneumocytes that are responsible for your gas exchange. They're only 1 cell layer thick. You're talking about very fragile tissue here. So you want that blood to come into your lung and be very low pressure because you want it to be able to go and contact these alveoli and be able to engage in gas exchange without a lot of pressure, without damaging any of that tissue. So it's a very low pressure. Well, whenever you have low pressure, you're going to be more affected by gravity, okay? So if you think about the fact that generally speaking, we're standing upright and we have the apex of our lungs, which is the top of our lungs, right? That's where our conducting zone is. That's where we don't have very much blood flow. And then we have the bases of our lungs, which is where all our alveolar sacs are, right? And that's where most of our blood flow is going to go. And again, this makes sense from a gas exchange point of view because your alveolar sacs are where you are going to be doing all of that respiratory zone gas exchange. So that's where you want most of your blood flow to be, okay? So this occurs in everybody normally, and these are your two anatomic shunts that create perfusion without ventilation. So going a little bit further on this regional differences, specifically what it's called is a VQ mismatch. So the V stands for ventilation. Very specifically, it stands for alveolar ventilation. A lot of time it's just simplified to ventilation, but we're talking specifically about ventilation in your alveolar air sacs. And Q stands for your capillary blood flow, right? And this little dot, which I am really bad at formatting, should technically be above both the V and the Q. You're going to see it without the dot most of the time. I try to do it one time the correct way, but these dots are little buggers and they move around, and it's not really that big of a deal. So V is ventilation, Q is blood flow or perfusion. So the normal VQ ratio, right? Because anytime you have a number above another number, you're going to get a ratio. The normal is 0.8. And this is where that respiratory quotient from your alveolar air equation comes from. It's referring to the VQ mismatch in the lung because of regional difference in the lung. So if you want to think about it this way, for every liter of alveolar ventilation, it should be matched with 1 liter of pulmonary blood flow. Ideally, you want a 1-to-1 ratio. You want your ventilation to be perfectly matched up with your perfusion, but that's not what happens. So where this 0.8 comes from is it takes the apex, the middle of the lung, and the base of the lung all into consideration, and the average VQ ratio for your lung, the average is 0.8, and that's where this number comes from. And I have a diagram where I'll show you a little bit more specifically what I'm talking about with that. But that's where this respiratory quotient comes from. So again, this is going to be a huge concept, and it's going to follow you through this program. So we're going to dig in and hopefully get really good comprehension out the gate so that you guys can do well with it. So one thing I want to point out is your alveolar oxygen, and I don't know how much you guys did with arterial oxygen in survey, so I'm just going to kind of touch on this for a second. Your alveolar oxygen, right? This is what we're getting with our alveolar air equation. This pressure of alveolar oxygen does not equal your arterial oxygen. Okay, why is this important? So you have to think about the fact that if you're diffusing oxygen from your lungs into your bloodstream, it would seem like if all of that diffuses, they should be the same. You should have the same pressure of oxygen in your lungs as you do in your blood. The reason that you don't is because of these regional differences in your lung and because this right to left shunt. So your arterial oxygen level is always going to be a little bit lower than the pressure of oxygen that you have in your lung. And it's because of these two shunts that occur naturally. The other thing, or the other component of shunts that we're going to talk about is your alveolar shunts. So in the same way that we talked about anatomic and alveolar dead space, you also have anatomic and alveolar shunts. So again, that anatomic is that naturally occurring, everybody has it, good, bad, or ugly. The alveolar shunt is going to be caused by a disease process. So COPD, restrictive disorders, obstructive disorders, fluid, atelectasis, pneumonia, I mean, this list is extensive. So really any condition any condition that results in compromised ventilation. Because again, a shunt is having perfusion without ventilation. So anything that is going to compromise your ventilation in any way, shape, or form is going to be something that is going to create more of a shunt. So that is what we're talking about here. So you have your anatomic shunt, normally naturally occurring. We talked about the two things that make that up. This is your alveolar shunt, and this is going to be more your disease process that shouldn't be naturally occurring. And if you guys just give me 1 second, I have to plug in my laptop, so I'm futzing around with stuff here. Okay, we are good to go. So, physiologic dead space and physiologic shunt are just the sum of the two things. So physiologic dead space is your anatomic dead space, which is your naturally, normally occurring dead space. This is your conducting zone, plus your alveolar dead space. And this would be caused by some sort of disease process that would be blocking your blood flow, because dead space is having ventilation, not having perfusion. Your physiologic shunt is your anatomic shunt, which is naturally and normally occurring. That's your venous drain off, your, I'm never going to say it right, Thespian drainage. And then it's also the regional differences in your lungs caused by that low pressure, gravity dependent system. And then your alveolar shunt is caused by a disease process, because again, your shunt is going to be having perfusion but not having ventilation. I get kind of redundant on this because, again, this is a huge concept. So anatomic dead space, all of your conducting zone. Alveolar dead space is alveoli with ventilation but no perfusion. The two together are your total physiologic dead space. Okay, the definition of your physiologic dead space is the sum of your anatomic and alveolar dead space, which is the total volume of wasted ventilation or physiologic dead space. The reason we call it wasted ventilation is if you have no perfusion to line up with your ventilation, then it's just kind of wasted. It doesn't matter how much oxygen is in those alveoli. If there's no blood or perfusion to come pick it up, then it's wasted. They say about 1/3 of our tidal volume is lost to physiologic dead space. And so the ventilation that's left over, they refer to as alveolar ventilation. And that's where that very specific term came from in the VQ mismatch that we talked about earlier. I don't do a ton with this other than to just let you know that of the total tidal volume that you bring in, only a certain portion of it makes it into your alveoli where it can be used for gas exchange. And that's why they call it alveolar ventilation versus just ventilation, because this is the portion of your tidal volume that's really going to be utilized. That's about all you need to know about that. There's like fun equations you can do with this, but I haven't found it to be very beneficial, and I don't really think it makes sense to include it. So this small little snippet is all I'm going to utilize for that. Okay, anatomic shunt and alveolar shunt. Your anatomic shunt is your two right to left anatomic shunts in the body, your bronchial and your Thespian, I said it right that time, venous drainage. And the other anatomic shunt is your regional differences in the lungs, and those occur because you have this low pressure system, and so it's very gravity dependent. Your alveolar shunt is going to be alveoli with perfusion but no ventilation, and this is going to be caused by some sort of disease process. It would not be normal or natural. Again, I know these are redundant, but it's just a very important concept. So your physiologic shunt is your anatomic shunt in addition to your alveolar shunt, and I have them described again here. And then the definition, the sum of anatomic and alveolar shunt are going to equal your physiologic shunt, and this is the total volume of wasted perfusion, right? And it's wasted perfusion because here you have all this blood flow that's coming, right? And it's got CO2 that it needs to drop off, but it doesn't have any ventilation to drop off CO2 or to pick up oxygen. So it's wasted perfusion. The dead space is wasted ventilation. This is wasted perfusion because this is the component that we have and we're missing the ventilation. We have the perfusion, we're missing the ventilation. These two together create a VQ ratio, a ventilation and perfusion ratio. A perfect match of ventilation and perfusion would be 1, right? You have the same amount of ventilation as you do perfusion, so you would end up with a ratio of 1, but it's not a perfect match. The average throughout the lungs ends up being 0.8, and this is that number from your alveolar air equation. This is your respiratory quotient. So to show you what I'm talking about here, there's this diagram, and I really like this diagram because for me this kind of like lands it the best from a visual standpoint. So here at the apex of your lung, you have your alveoli here, and it shows you this tiny little blood flow here, right? Compared to your alveoli, you have all this ventilation, and you have very little perfusion, right? So your ventilation over here is much greater than your perfusion. So your VQ ratio is going to be more than 1. And I try to show this by making the V very large compared to the Q. So at the apex of the lungs, you have this VQ ratio of more than 1 because you have all this ventilation, not very much perfusion. This is considered zone 1 of the lungs at the apex. Zone 2, which is in the middle of the lungs, your ventilation does equal your perfusion. Your VQ ratio does equal 1 in the middle part of your lungs. The issue is the mid part of your lung is not, it doesn't comprise very much geography of your lung. It's not a very large portion of your lung. It shows you that you have this nice sized alveoli and it's very well matched with the blood flow that you have, but this doesn't comprise a lot of the gas exchange because it's just not a very large part of your lung. This base of your lung, zone 3, is going to have a ton of perfusion because again, think about gravity dependent. The blood flow is going to want to go to the base of your lungs. Ton of perfusion, not very much ventilation, right? So your VQ is going to be less than 1. The thing that's, I think, the trickiest about this is where most of your gas exchange occurs in zone 3, right? And although you have less ventilation in your bases than you do in the mid-lung or the apex of your lungs, you still have significantly more surface area for ventilation to occur. So even though your alveoli are smaller, and you have significantly more perfusion than you do ventilation, you have so many of these air sacs in the base here, and they're able to expand so much during each breath that this is really where almost all your gas exchange is occurring compared to the mid-lung or the apex. This is why most of the disease processes that affect the lung, we target the base of the lungs to clear out fluid, we target the base of the lungs to clear out infection. When we're doing hyperinflation, this is really where that respiratory zone is the most, effective. This is where most of this happens. So your VQ is less than 1 because you have less ventilation than perfusion, right? So the average of these, so you have it more than 1, equaling 1, and less than 1, the average of these 3 zones is that 0.8. That's where that number comes from. Okay, and this is just showing you that VQ ratio for each area of the lungs. And this is what we're talking about when we're speaking about regional differences that naturally occur. Okay, so another way that I put it, high VQ or VQ greater than 1 means that ventilation is going to be greater than perfusion. A low VQ would be less than 1. And ventilation would be less than perfusion. So I'm just saying a lot of the same things over and over in different ways, but it's just, again, trying to land this. So regional differences, again, going to circle through. Regional differences are mainly caused by gravity. They're most evident in the upright lung. I'm sure you guys have heard, not to segue, but I'm sure you guys have heard about with COVID patients how they are proning them, and they're finding success in oxygenation when they prone them, which just means that they lay face down. And we won't go into the details of how that works. I don't want to confuse it, but if your blood flow is gravity dependent and you put somebody on their belly, you prone them, it makes the blood flow shift from the bases of their lungs in an upright lung to the anterior portion or the front of the lung. And what it does is it gives you the ability to hopefully help offset that VQ mismatch. Because what's happening with these patients is they're getting like a COVID pneumonia. So try to imagine that their alveoli are just filled with junk. We won't go into the specifics of what, but they're just filled with junk. So they have poor gas exchange, right? If you're thinking about fixed law, their surface area is compromised. Their AC membrane thickness is more thick than it should be. So what we do is we put them on their belly and it shifts their blood flow from the bases of the lungs to different regions of their lungs to hopefully optimize their oxygenation and send it to areas of the lungs that haven't been compromised by this COVID pneumonia, okay? There's a lot of things we can do positioning wise because it's a gravity dependent blood flow that can help oxygenation or help ventilation for these patients. So again, this happens because your pulmonary circulation is a low pressure system. So blood flow is variable from the top to the bottom of the lungs. And this is when you're thinking of an upright lung. So picture somebody standing in a normal position. So perfusion increases 20 times in the bases compared to the apex. Ventilation increases 4 times in the bases compared to the apex. So again, even though the base has less ventilation than it does perfusion, it still has significantly more ventilation than the apex. This is really, the bases is where your gas exchange is happening. So this shows exactly what I showed or said earlier. It's just in another way. So your lung apex, your ventilation is greater than perfusion. It's a high VQ. The actual number is like 3.3. You guys do not need to memorize this. I'm just telling you. In the middle lung, the ventilation is going to equal perfusion. It equals 1 because they're equal. In the lung bases, ventilation is less than perfusion, so you have a low VQ. It's around 0.66. The sum of these, or the average of these, is going to give you that 0.8, which is your respiratory quotient from your alveolar air equation. Distribution of ventilation. In your apex, your alveoli are more inflated at rest. And all this means is no matter where you are in your breathing cycle, the size of your alveoli at the apex, they don't really change that much. They're not really moving all that much. They're about the same size all the way through your ventilation cycle. And then again, at the apex, you have more ventilation than perfusion. At your base of your lung, your alveoli are less inflated at rest. So that just means if you're not actively inhaling, your alveoli are kind of collapsed down. The alveoli in your base, they expand more with each breath. And we talked about things that can help that, like PEEP, for example, keeping them stented open so that they're easier to inflate. But there's a lot more size change in the alveoli and the bases throughout your ventilation cycle. And there's more perfusion than ventilation in your base. Again, I know some of these are repetitive, but I just really want to make sure that we understand this as best we can early on. So in the apex, you have greater volume. They're less compliant. Your alveoli are not changing very much in the apex. Less volume change with each breath. And then there's less ventilation per minute because, again, we're not doing very much gas exchange in the apex. In the base, you have the smaller volume. They collapse down more throughout the ventilation cycle, but they're more compliant. They stretch, they open back up. You get a greater volume change with each breath, and then more ventilation per minute in the base because this is really where our gas exchange is occurring. This is going to show you a different breakdown, but a lot of the same information. So in the apex, your VQ ratio is about 3.3, mid-lung it's 1, base it's 0.66. The average of all those is that 0.8. This shows you the average PaO2 in each area. And what you'll notice is in the apex, you have a really high pressure of alveolar oxygen, whereas in the base, it starts to get lower. And then over here, if you look at your CO2 in the apex, it's very low compared to the base. And if you think about why that is, it'll kind of help the logic here. In the apex, you have very little perfusion. You have very little blood flow. Well, what's bringing in our CO2? Our blood flow, right? You're not inhaling CO2, you're inhaling oxygen, you're removing CO2. So here at the apex, you don't have as much perfusion, you don't have as much blood flow, and the blood flow is going to be what brings that CO2 back to your lungs, right? In the base, you have much, much more perfusion, so it's bringing more of that CO2, it's bringing more of that CO2 into your lungs, so that number is much higher than at the apex. So I feel like I said that in a confusing way because I jumped from oxygen to CO2. Sorry, it's weird to talk to a screen out loud. Let me start that again. Your oxygen, your apex is high because you have ventilation. Your oxygen, your base is going to be lower because you have less ventilation than at your apex, which we talked about. In the bases, right, you are going to have more CO2 in the base than you do in the apex. And the reason why is we have more perfusion in the bases, and the blood flow is what brings the CO2 back to the lungs. So if you look here, you have significantly more CO2 in your bases than you do in your apex, and that's because here you're looking at the perfusion difference. Blood is what carries your CO2 back, and that's why that number is higher in the bases than it is in the apex. Sorry that I kind of jumped around there. We are going to hopefully really dig into this in lecture. Again, have questions prepared, email me questions. I'm going to try to find some videos or some more diagrams to talk through this in class. I think that this takes a little while to kind of dig into and get your hand on it. But if you, before Tuesday, know your definitions in this PowerPoint really well, I feel like it's going to help you when we kind of go through it in discussion. So these are your lecture questions. I have up here at the top just anything that worsens VQ mismatch will impact ventilation. This is going to make it more difficult for oxygen and carbon dioxide to diffuse properly. Ideally, we want the VQ to be 1, right? That means that ventilation will equal perfusion. That's not the case because of anatomic reasons that we talked about, but we don't want any disease process to worsen VQ mismatch, all right? And when you think about what you're going into as a respiratory therapist, we're seeing patient populations that do have extra compromise to their ventilation because of disease processes, right? Not this anatomic reason, because of that alveolar deadspace or alveolar shunt being worsened because of disease processes. And it's our job to really understand how we can fix that, how we can treat that, how we can support that person in the meantime until that can be corrected. And so this is kind of really the nuts and bolts of a lot that you're going to be doing with disease and therapies and things like that. So I really want to make sure that we have good comprehension on this. So we're going to spend some time on this. So please come to the next lecture with either questions or when we go through the discussion. Please don't be afraid to speak up if this isn't clear after we give some more examples. And that is all I have for this one. I know this was kind of a lengthy one, so thanks for hanging in.